Hi, this is Brian Romers recording a lecture for medical surgical nursing, and today's topic is going to be on valvular heart disease, endocarditis, myocarditis, and pericarditis. Within this, we're going to look at patients that have valvular heart disease and compare and contrast the different valve disorders. We're going to look at infectious cardiac conditions, including endocarditis, pericarditis, and myocarditis. We're going to talk about some of the valvular heart diseases. We're going to look at nursing interventions for those who have infectious and non-infectious valvular heart disease. And we're going to talk about some of the teachings that can be done to promote health and prevent worsening of cardiac dysfunction. So all too often what we're seeing here with cardiac or with heart valve disorders, we often will see this as a result from hypertension or some kind of valvular disease where blood regurgitation leads to left or right-sided heart failure. And so specifically, some of the things that we're going to be looking at would be like mitral stenosis, and so this is often related to fibrosis and rheumatic carditis or rheumatic fever type of situation. You can get mitral regurg, so this can be related to insufficiency, related to age, infection, ischemia, or congenital abnormalities. So stenosis means tightening, so it gets too small and blood can't go through. Regurgitation means that it's too big and blood is leaking through the back way. So it gets forced through, but then due to pressures and maybe it's not closing well, you're going to see flow backwards. Mitral prolapse, so this is prolapse related to congenital conditions, just kind of falls apart a little bit. Can be a familial tendency with this one. Aortic stenosis or narrowing, that's caused by thrombosis and narrowing related to wear and tear from hypertension oftentimes. So otherwise regurgitation, and so you're getting that backflow through that valve. So what are we seeing for some of the assessments? So family history, so if they've got a long family history of this, then it's not uncommon that they will undergo this as well. Medical history, rheumatic fever is a major component for this one at some point in their life. They could have had infective endocarditis. Use of antibiotics will often prevent some of this stuff with rheumatic fever and infective endocarditis, but not always. Socially, IV drug use can put them at risk for cardiac infections, leading into this valvular disorders and destruction. Activity intolerance, so they're going to have angina, chest pain, dyspnea, and some palpitations. So objective, you might be able to feel some of the palpitations. They'll be fatigued. There's going to be some weight gain with this one, some changes in there'll be edematous. The extremities will be cool, pale, and have some weak pulses. You'll hear a murmur, shortness of breath, crackles, angina, syncope, some dysrhythmias. So what kind of diagnostics can we do? Well, we can do imaging. So we can do an echocardiogram, which is an ultrasound of the chest, and we can see that. We can do a transesophageal echocardiogram, so we're doing this down the esophagus, and that gets us a little bit closer. We don't have to worry about the bones or the ribs being in the way, and we can get a little bit better pictures. We can do exercise tolerance testing, so ETT, so we'll put them on a treadmill and see how they function with this. Otherwise, this can be simulated using drugs, so they get an injection of some medications, and that can cause some like some epi and those kind of situations where they have increased heart rate and stress test that way. Can do a chest x-ray, so looking for increased size or any pulmonary congestion. Other diagnostics, ECG, so looking at the 12 lead to see if they've got changes in rhythm or other abnormalities. So interventions, what do we do with this? Drug therapy is probably one of the most highly sought after things that we do with this. So we'll put them on diuretics to decrease the amount of fluid in that vasculature, and hopefully it pushes less on that, especially with your regurges. Beta blockers, digoxin, oxygen, trying to prevent and improve any symptoms of heart failure. We can put them on prophylactic antibiotics, especially if they've had valve replacements, or if they've had a history of infectious disease into their heart and into their valves. Medications to restore normal sinus rhythm, so diltiazem, amiodarone, could cardiovert as an option if they are having significant electrolyte or electrical changes. And we might anticoagulate. So if they've got chronic AFib, they're really at risk for having small little clots there, and those small clots can lead into big problems. We can do reparative procedures such as balloon valvuloplasty. So what we can do with that is if it's too tight, we can put a balloon through there and then inflate the balloon and get that to open up. We can do a transcatheter aortic valve replacement. I think this is so incredible that we can use, we can put a whole new valve just going through the vasculature and not necessarily having to do an open chest anymore. But if that fails, then we can, of course, do open. And then we can do a reconstruction. This is an open thing usually too. So we can do a cabbage. And so with some of these kind of things, so coronary artery bypass graft, and with that we're bypassing the blood flow. We can use synthetic or biological type of tissues to make these grafts. And so that's another option. But I'm seeing way less of these as we're able to do more of this transcatheter aortic valve replacements and doing more stuff with being less invasive. So I'll let you look through that. So patient had heart valve replacement, taking Coumadin. What things interact with your Coumadin? And that's going to be vitamin K, so kale and spinach, and that's going to actually counterbalance your Coumadin. And that's one of the things that you're going to want to watch for. They can have this stuff, but they should try and kind of maintain unstable things. If they eat a lot one day and then not so much the other day, that's really going to mess with their Coumadin, and trying to get to a stable level will be difficult for the provider and for you. So the other ones are pretty good. All right. So self-care emphasis, so medications, activity, weight, diet. I don't think that this is going to be anything really new for you. And then reporting any new symptoms. So as we're doing self-care, these are maybe some of the things that they really need to focus in on. And then great resources here. American Heart Association, of course, is going to be talking about this. Infective endocarditis, so you get vegetation, it's a fancy word for it, but you get bacteria or fungal matters that is on the inside of the valves and it causes destruction. Strep viridans is a very common form of this, and you have a lot of this in your mouth, so this is very common after like dental procedures. So if they are scraping on your teeth and scrape your gums, and some of the bacteria goes into that bloodstream and goes throughout your body, that's a common way to get endocarditis. Staph aureus is another one, very common. Everybody has got these on their person. They're growing on our skin, on our tissues, and so that's how you self-inoculate yourself. Patients are at risk. If they've ever had valve replacement, any plastic within their body is a big risk factor for infection. IV drug use, systematic infections, any cardiac defects, which is causing turbulence and causes a place for this bacteria to kind of grow. Immunodeficiency, which is causing this to grow. Diabetes mellitus is a risk factor for this because of the increased sugar. So common portals of entry, like I said, oral cavity, any skin infections or interruptions can go into the bloodstream then. Invasive procedures like surgery or those kind of situations as well. So what are you going to see on assessment? So oftentimes they have a fever if it's infective. They're going to get murmur. They'll go into a heart failure. They could have embolization. And so those little clots and stuff like that can break off, and this can go throughout the body. When that does it, you can get into petechiae, so the little hemorrhages on the skin from blood from the vasculature rupturing. You might see splinter hemorrhages. These are on the back of your nails, and that's basically a petechiae of underneath your fingernails. You can get Osler node, Janeway lesions. These are both like on your hands. You get these bumps. And then fatigue and confusion. So diagnostics, you're going to do blood cultures, see what's growing, see if it's viridans or Staph aureus, and then you'll look at echocardiograms and a CBC. Interventions, antibiotics are going to be your best bet if it's bacterial. If it's fungal, then of course antifungals. But then you're going to treat and the heart failure. And then if it gets bad enough, if it damages those valves, then ultimately you might have to do a valve repair. So hopefully early recognition will prevent a lot of the long-term complications with this one. And then the antimicrobials will help with that. And then from there on out, anytime they have an invasive procedure, such as dental work or surgery, they're going to be put on antibiotic prophylaxis, trying to prevent this from happening again. Myocarditis, so this is damage to the myocardium, often by a virus. I've seen this with influenza. So we kind of poo-poo influenza, so to speak, but I have seen this cause patient to actually die because of the damage to the myocardium. So leads into heart failure, cardiogenic shock, chest pains, dysrhythmias, dyspnea, palpitations, and syncope. So you can pick up on it using labs. Echo is a big thing with this one. MRI somewhat, and myocardial biopsy if you're really going after it. So what do we do for this? So administer the medications as ordered. So we're looking at the heart failure and trying to minimize that. Of course, if they're in shock, we're treating that. If they're having palpitations, then of course we're treating those as well. So, and then a lot of this is providing emotional support, because this can be very scary if things are impacting your heart. Pericarditis, so this is talking about this outer level of the heart, and so you're getting inflammation with that, or possibly infection with that. And so could be related to infection, post-MI, or exacerbation of your CTD, which is connective tissue disease. So assessment is going to include some precordial pain with radiation. This will increase when they're supine, but when they're sitting up, it will be better. It's probably not gone, but better. You might hear a precordial rub, depending on what area this is that's inflamed. Body might be in an upset position, so you're going to see changes in your WBCs, which they'll be elevated because your body's stressed, and they might have some symptoms of heart failure. Diagnostic-wise, blood cultures to see if anything's growing in there, EKG, X-rays, echo, MRI, CT are common diagnostics findings, trying to look for that inflammation there. Intervention, so pain medicine, so trying to decrease that inflammation, so NSAIDs, prednisone, antibiotics if it's a bacterial type of an infection. And of course we're going to do like looking for cardiac tamponade, or if there's pericardial effusion there, in which you're hearing muffled heart tones and different things like that, then what you might have to do is actually put a needle in there and drain it. So that concludes this lecture. If you have any questions on these items, please feel free to contact me.